So Megan Quinby is the Director of Speech and Language in the Frontal Temporal Disorders Unit, FTD, at Mass General Hospital. She specializes in working with individuals with progressive language disorders, helping them by providing evaluation and treatment services that focus on helping functional communication. Megan is an active clinician and a researcher in the FTD clinic and research unit. She also co-facilitates the primary progressive aphasia, that's PPA, and you'll learn a little bit about that tonight, education and support group, and she provides education to many organizations such as the Alzheimer's Association to increase public awareness about progressive aphasias, because I, who have worked here for over 30 years, frankly, not until joining Megan and her colleagues 2 years ago did I learn about PPA and its etiology, its cause in relationship to a neurologic problem. So it's new to even those of us who think we know a little bit about the brain. Megan has worked at an adult day health program, Constant Therapy, which is a speech-language iPad application company, and Mass General as a research coordinator doing Alzheimer's research. Here's the good stuff. How does she get it all done and stay wonderful and kind and compassionate? Outside of the clinical and research world, Megan loves hiking in Maine and sitting on the rocks by the coast to watch the water and birds. And it is my great honor to introduce our colleague, Megan.
What Barbara didn't mention is that I really enjoy working in the FTD unit and with caregivers and patients. It's always been a passion of mine to work with people with dementia, and communication is so important. So I really love my job because I get a focus on helping people communicate and hearing their voice. So if you have any questions after the presentation, I'm more than happy to answer any of them. And then afterwards, I can also meet with people individually if they have any questions specifically about their loved ones. So to begin, I just wanted to go over the importance of an interdisciplinary approach. Many of you may have seen neurologists or primary care physicians. But these diagnoses are rare that I'm going to be talking about, and it's really hard to get an accurate diagnosis. Many times caregivers come to me and say they were misdiagnosed several times before their loved one got an accurate diagnosis. So in addition to neurologists and other physicians, it's really important to work with neuropsychologists, speech-language pathologists, social workers, and resource specialists, because they all add a little bit to what's going on in the diagnosis. There's different types of testing, there's different types of interviews and information that they get from those. So really you want to work with a team of specialists in these diagnoses in all these different areas. And today I'll be going over specifically what speech-language pathologists do with this population of patients, but we have a team that works with all these different types of health professionals, so I can answer questions about those too if you have any. So the agenda for today, I'll be going over diagnoses where speech and language are the most affected. The diagnosis that has the most speech and language deficits is primary progressive aphasia. There are 3 different subtypes, so I'll be going over those in more detail than the other diagnoses. But I'll also be going over other diagnoses that have speech and language difficulties as well. So some of the challenges there, and then I'll also be going over some of the therapeutic approaches that speech and language pathologists do with these types of patients. So some general terms that will help in understanding the different diagnoses I review is frontotemporal degeneration. It's a disease process that causes changes in behavior and personality, language, and motor skills that leads to a deterioration in a person's ability to function. Different diagnoses incorporate different declines in these areas, and I'll be going over that in more detail. Dementia is a pretty heavy term, and it's often misused. When you think of dementia, it's really an overall term that describes a wide range of symptoms associated with a decline in thinking skills that reduces a person's ability to perform everyday activities independently. So really, a diagnosis of just dementia is not really an accurate diagnosis. Really, all that means is that a person's not able to function independently in their daily activities. For instance, doing their finances, taking care of the house, bathing. We describe activities of daily living, which is like taking basic activities like washing yourself, keeping yourself clean, brushing your teeth, whereas IADLs are referring to more complicated activities such as doing the finances, planning activities, planning family trips, things like that. And so once someone is not able to do those things independently and needs any type of help with those activities, then we would give them what we call a functional cognitive status of dementia. And I'll be going over that more in some of the future slides. And when I'm going over these different diagnoses, it's also really important to know the difference between speech and language. So language is the expression and understanding of thoughts, ideas, concepts using a shared symbol system. It's basically the ideas within your head. And speech is one of the ways of getting that language out through the physical productions of the sounds of a language through your mouth. So there are other ways to get language out, though, other than speech. For instance, sign language, written words, and gestures. And this slide has a lot of information on it, but I'll be going over all these different diagnoses. This is a slide with the different types of diagnoses that we work with. Sometimes ALS has also incorporates frontotemporal dementia within that diagnosis. I'll be speaking less about that diagnosis, but if anyone has a loved one with that diagnosis, I can speak with them in more detail. I'm making the assumption that most of the people in the audience have some involvement with these other diagnoses that we more often work with, which is behavioral variant FTD, where the main symptom for them is a decline or changes in behavior and personality. Corticobasal syndrome and progressive supranuclear palsy, their main symptom usually when involving a speech-language pathologist is with speech, so the actual pronunciation of words. And then there's 3 different subtypes of primary progressive aphasia, the semantic variant, the non-fluent or agrammatic, and the logopenic, and I'll be going over those in more detail as well. So this slide also has a lot of information on it, but I think it's one of the most important slides that I'll be reviewing today. This is how, when someone comes in, a caregiver and their loved one comes into our clinic, and they're asking for either a second opinion or an accurate diagnosis, this is what we think about. And it has 3 different parts. It's not just one word that describes the full symptoms and the whole picture. We think about all 3 of these things when making a diagnosis. And so for the first one that we think about is global cognitive clinical status. And that's also sometimes we refer to it as a functional cognitive status. And that's how independently is the individual able to function in daily life. And so I went over what dementia is when they're no longer able to function independently. But there are also other options. For instance, cognitively normal is just, cognition is perfectly intact, no problems. Subjective cognitive concern is the person or a loved one may see a cognitive decline, but we are not picking up on that in testing or when interviewing the patient. So all the testing's within normal limits, nothing's wrong, but the person themselves feels like there is some type of decline. Mild cognitive impairment is we see a decline in their functioning from how they were before, but they're still able to function independently in daily life, and they still can take care of the finances, take care of the house, etc. But there has been a decline in compared to the baseline. And as I mentioned, dementia, they're no longer able to function independently in those daily tasks. So that's the first part of the diagnosis we think about. And then the second is the cognitive behavioral clinical syndrome. And the way we think about that is we interview both the caregiver and the patient to look at the symptoms, as well as We do cognitive and language testing to think about the signs and which clinical syndrome best fits those symptoms and signs. For instance, PCA, which stands for posterior cortical atrophy, is associated with visual difficulties, where in an interview the caregiver may say, oh, they're perfectly fine and everything, but they're falling a lot because they can't see in front of them, or when you give them a piece of paper, they can only see the left side of the paper, or different types of visual stimuli they can't interpret in the right way. Whereas PPA, the main concern would be speech and language. And then BVF, behavioral varying FTD, changes in behavior or personality. So we really think of the whole picture. It's not just the testing, it's really the interviews with the caregiver and the patient that are really important too. So that's why when you come to us, it's really important that you are looking at how your loved one is functioning in daily life, because that information is just as important as the testing that we do with the patient. And then once we think about the clinical syndrome, then we think about the underlying pathology that's causing these symptoms. So is it Alzheimer's pathology? Is it frontotemporal lobar degeneration? What is causing these symptoms and signs? So there are different things that we look, different types of imaging that we look at to best figure this out. An MRI is something that we ask patients to get to look at the structure of the brain. So in what areas of the brain is there atrophy? And then there are different types of PET scans. One type of PET scan allows us to think about the functioning of the brain. It allows us to see where in the brain is it not functioning as well as it used to. And then there are new PET scans which allow us that have different tracers that allow us to look at some of these proteins in the brain that we think are causing the atrophy to happen. And those are kind of new age technologies that didn't exist 5 years ago. So for instance, amyloid in the brain that's associated with Alzheimer's, now they have these new PET scans that are what we think they're connecting to are the amyloid in the brain that allows us to see, oh, where in the brain are these proteins affecting the brain and making the neurons die. So really when we're giving a diagnosis, we're thinking about all these three things: the functional status, the clinical syndrome, and the underlying pathology that are causing these problems. So next I'll go over primary progressive aphasia, a language disorder due to damage to parts of the brain that started sometime after birth. You can have an aphasia from a traumatic brain injury, you can have an aphasia from a stroke, and you can also have an aphasia from a neurodegenerative disease such as Alzheimer's or PPA or something like that. And it's called primary progressive aphasia because it's a language disorder, so an aphasia that gets worse over time, so it's progressive, and the primary problem is language. So in order to have a PPA diagnosis, within the first 2 years, the problem should be isolated to speech and language. Other diagnoses have issues with speech and language, but for primary progressive aphasia, the beginning symptoms should be isolated to speech and language for it to be called a PPA diagnosis. And so frontotemporal degeneration is an umbrella term, and there's a lot of different diagnoses that go under that term, and primary progressive aphasia is one. And then there are 3 different subtypes: the non-fluent, the semantic, and the logopenic. And so to help describe what these different subtypes look like, I have videos, but for the first one I'm going to have to use my laptop because it's not working on this computer.
Yesterday was waiting my garden.
Waiting? Can you write it down for me?
Weeding her
Yes.
garden.
Oh,
Yes.
weeding your garden. I'm sorry.
Allergic get AC.
You're brave keeping a garden when
Yes,
you've had
yes,
allergies
yeah.
like that. Wow, that's amazing.
So the
AC makes me get congested.
can you say the full word for AC?
Air condition.
Okay,
Air condition.
good.
Ing.